Yes.
Oh, now
Thank
we
you.
are. So we start with the second. Well, as I said, talk is divided in 3 parts, as you heard. Now we come to this slide, yes. What we like to have in the when positioning the components in safe zone is maximizing the range of motion. And in the same time, we'd like to minimize the risk for prosthetic impingement, which also reduces the risk for dislocation. And third, we'd like to have recommendations for the positioning of the components so that no impingement occurs. And this should be based on facts rather than opinions. As probably all of you know, the term safe zone has been introduced in total hip arthroplasty in 1978 by Luvinek. He described a zone for cup inclination and cup anteversion, which is quadratic in shape. Each size is 20 degrees long, 30 to 50 degrees for inclination, and 5 to 25 degrees for cup anteversion. And according to him, the cup inclination and anteversion should be within the green zone in order to minimize dislocation. It is important to know that his recommendation is clinically based and that he addresses the orientation of the cup only. Nothing is told about stem version, stem CCD angle. In order to analyze how range of motion and component positioning are correlated in a more functional way, I just set up a computer model which allows to visualize hip motion and to investigate how the best component position to achieve a predefined range of motion can be achieved. The blue tracks on these heads demonstrate where the prosthesis neck travels when performing a flexion extension, abduction, or internal-external rotation. Obviously, these tracks should be uncovered by the cup in order to allow these movements. Otherwise, there is a conflict between the neck and the cup, and this will limit motion and may cause dislocation. But which should be the range of motion we should aim for? We can refer to Kapanchi's and Hoppenfield's publication, where they define this kind of range of motion, or the ones of Mickey and his at home. They reported about a range of motion which is more suitable for the operated hip. The red skirt of Kapanchi's image shows the envelope of motion where the right leg is circumducting, and it is clearly visible that flexion and extension are the dominating motion within this envelope. Now, starting to develop in the safe zone, you can see here that we start by defining an IROM. That is the intended range of motion, the range of motion we want to give the patient. After calculating a number of different orientations of the components, you get clear directions on how to position the cup. The red oblique line is the 130 flexion curve. In order to allow at least 130 degrees of flexion, the cup should be positioned in the upper right side of this curve. That is the green side of the curve. Combinations in the lower left corner do allow lower friction rates only. If you introduce the extension, the 40 degrees of extension, this does restrict the zone in the upper part of this diagram. That means only positions lower than this extension curve line allow at least 40 degrees of extension. Adding the abduction does not change much, only at the tip of this zone, but adding adduction reduces this zone considerably. And introducing external rotation does not alter this zone anymore, and adding internal rotation does not alter it at all, as it is outside the last zone. So because of biomechanical reasons, we should fade out inclinations above 50 degrees, and so finally we get this green safe zone. All orientation of the cup for inclination and antiversion, which are in this zone, allow at least this intended range of motion. When we compare it to the safe zone of Luvinek, we have to realize that overlapping occurs in the upper right corner of Luvinek's zones only. The reason for this is probably the 100-degree flexion that we intend, and we know that the apparent flexion of the leg is a composed one. It is composed of backwards tilting of the pelvis and of real flexion within the hip joint. So reducing the intended flexion to 120 degrees would be helpful and give us additional space within this zone. So enlarging this green safe zone. But still, it is remarkable that overlapping occurs in the upper right half of Luvinek's zones only. So, finally, this leaves us to an envelope for the prosthesis that is comparable to Carpenter's red skirt. You can choose a target zone for your cup, which is indicated by this ±3 target zone, that will fulfill the criteria for the intended range of motion. So a cup position of 40 inclination and 20 degrees of antiversion is probably correct. But if you prefer 45 for the inclination and 15 for the antiversion, you are still correct. Now I'd like to draw your attention to these parameters on the right in the inferior corner of the diagram. There you see that these calculations and this safe zone is only valid for a straight stem with a CCD angle of 130, a head-neck ratio of 1.3, and the stem is implanted in 15 degrees of antiversion. So the question arises, what happens when we are modifying one of these parameters, the antitorsion, for example, of the stem? Here I have the green zone in the middle again, and two zones in the upper and lower part. And the upper one is the red one, which stands for 10 degrees of stem antitorsion, whereas the purple one stands for 20 degrees. So the zone is shifting when you are altering the orientation of the stem. What we can see is that there is a connection, and there is a compensating effect for the versions of the cup and the stem. When you increase the stem antitorsion, the cup antiversion should be decreased, whereas when you increase the stem antitorsion, the cup antiversion should be decreased. So completing the analysis for more versions, we can see that the shifting is continuing, but also that the shape of the safe zone is not constant, it is altering. When we place our targets as shown here in these red ±3 circles, we get a second scale, which is in this blue frame. This is the zone for the antitorsion of the stem. And when comparing them to the antiversion of the cup, you see that it's ordered in a reversed direction. If the antitorsion of the stem goes down, the antiversion of the cup goes up, and vice versa. This is the compensating effect between stem and detorsion and cup inversion. And going back to mathematics, we can get this simple correlation between the stem and detorsion and the cup and inversion. So cup and stem are linked linearly with respect to inversion. This correlation could be confirmed. There is another aspect. Before, you see there is a factor of 0.1 before antitorsion of the stem. That means that the impact of the stem to contribute to the sum of this equation is 30% less than that of the cup. And he's at home, he made a comparable analysis, and he came to this dotted line, and this line is shifted 5 degrees upwards because he was using a CCD stem with a 135 angle instead of 130. Completing the analysis for the anatomic and operative definition, not only for the radiographic, which was before, gives you additional lines, and you can see that the compensating effect is still present. Now, the linkage between cup and stem is called the combined orientation of the two components. There is combined version, which means cup antitorsion and cup antiversion, and there is combined inclination. Cup inclination and stem CCD angle are also compensated. This aspect has been considered in a lot of papers in recent years and has attracted increasing interest. So when we address CCD angle, which is another parameter of component orientation, we see that stem CCD angle and the cup inclination are also closely correlated. As before, you have the green zone here in the diagram, 130 degree of CCD angle, which is normally a standard stem. And if you use stems with smaller CCD angles for a more varus type of prosthesis or for lateralized stems, you should consider two things. The first one is you should reduce the antiversion of the cup, the inclination of the cup a little bit, 0.5 degrees per CCD angle, but even more, you should reduce the antiversion of the cup as well, and 2 degrees per CCD angle. This is important. If you switch from a standard stem, which has a CCD angle of 131, to a lateralized one with 123, there you should shift your target zone appropriately. That means from the red to the blue zone, or if you know that a lateralized stem would be an option during surgery, you can choose a target which is in the overlapping zone. Just for completing this analysis, I show you the graphs for different head sizes. You know that increasing the head size will increase the head to neck ratio. Here are the examples for 2.1 to 3.3. And as you can see, this will expand the size of the safe zone more or less symmetrically. And that demonstrates the effect that you know that you will gain room for errors if you are using larger head sizes. The green zone, and for comparison, the luminex zone. So greater heads to cover the luminex zone even more. So what can we do in surgery when we know that cup and stem are linked? The question arises whether the cup should dictate the position of the stem or whether the stem should dictate the position of the cup. One solution is to use navigation without computer, or another is to use modular necks. In any case, you should consider that there is an individual tilting of the pelvis of the patient, And it has been pointed out by these authors. You may alternatively follow the recommendation of stem or femur first operating technique. That means that the stem is dictating the position of the cup. Obviously, the stem is more restricted in its rotational position when implanted into the femur, and therefore it is less adjustable. The cup is much better adjustable to the stem because it can be orientated in a different way, especially using hemispheric cups. And using some kind of navigation will help you. For example, you can use navigation, as I mentioned before, or you may use a very simple technique. And that is this kind of trial head, which has rings on its surface, and these rings show the relative orientation of the cup and the stem to each other. These rings on the surface, they indicate the optimal orientation, and additional rings define a 5-degree tolerance zone. So all you have to do during surgery compared to nowadays is to control whether the orientation of the opening plane is parallel to these rings or not. This provides a very straightforward way to control the orientation during trial reduction, as you can see here. And if they are not correctly aligned, like in this case, here the components are out of the tolerance zone, so you should correct the position of the cup, or in a modular implant, you may adjust the orientation of the neck in order to get a correct alignment. So in conclusion, I'd like to summarize that the safe zone is not quadratic, it is more or less polygonal. It shifts within the diagram upwards or downwards, and it also is variable in size depending on other parameters. And it should also be known that it is system specific, so there is not one safe zone, there is a zone for one prosthesis system. Second, you should have an eye on combined orientation, but the final position of the components is always a compromise between bone referencing, which means fixation of the implant and optimal range of motion, and you should not hesitate to use smart alignment tools. So I thank you for your kind attention.
Thank you very much, Karl, for your very nice lecture. And I want to invite